Good deal. All right, so today I have a lot of videos, so I will try to play them multiple times because I do know that Zoom is a pain in the butt for videos. But this is a very highly athletic horse, extremely Olympic horse, 24-year-old Missouri Foxtrotter, who was actually retired due to front pattern arthritis in June 2021. And when he retired a long time ago, excuse me, presented in June 2021, according to the owner, with an abnormal gait behind. And the owner just wanted to get a little bit of quality of life. That's about it. I see that my screen is paused. Do you guys? Screen sharing is paused. Great. Why would that happen? Can you see my presentation, handy dandy? Thumbs up? Yes. Good.
Yes.
So, good. So here is the video of Dottie. In this video, we can see a significant shortening of the cranial face of the stripe of the left hind.
I'm not seeing the video.
You're not seeing the video?
Nope.
Resume share. Screen sharing is paused. Let's try. Let's try this one. How about now? Can you see Dottie moving? It's a yeah, Dottie moving. Significant shortening on the cranial face of the stripe of the blocking out again. The left hind, right? Yeah, significant face of the short face of the stripe with a fast total movement and a slap in the ground. So this is usually very pathognomic for one disease, which is fibrotic myopathy. We quickly went and did an ultrasound of the thigh, and on the left side, you can see a fibrotic semitendinosus. Someone coming in. Oh, there you go. And on the right side, you can see the normal caudal thigh muscles. Here is a very tight band of the semitendinosus on the left hind, and obviously on the right is the normal one. Good. So here are more pictures. You can see the fibrosis, pretty extensive on this horse. On the left hind, on the semitendinosus muscle. We took some radiographs just to make sure that the stifle was okay, and other joints as well. We can see in this radiograph how there is a bisecting line, bisecting radiolucent line on the caudal thigh muscles. You can see that. Can you see that line? How do you point with this? There's no way to point, right? So that bisecting line is due to the fibrosis of that muscle. And you can see how a lot of the soft tissue opacity on the caudal thigh muscle over here. Now, for this horse, we ended up doing surgery on September. Actually, we did surgery. I don't know if the day is correct, but we ended up doing surgery, then stretching exercise, and with the underwater treadmill. This was how she was right after,
¿Y qué pasa?
right after surgery.
El clic de ellas al frente, ¿no? El de ahora.
Absolutely no improvement.
No.
We agree. So right after surgery, we saw 0% improvement. I'm gonna play it again. Actually,
¿Y qué pasa?
it might even look a little worse.
El clic de ellas al frente, ¿no? El de ahora.
Then after that, we ended up doing underwater treadmill for rehabilitation. You can see in the video that she actually looks a little better, extending the legs forward, extending that left hind a little bit further forward than after surgery. Then she went home with the instructions of stretching exercise and going over poles. I would say, and if you don't agree, I'm okay with it, that here there's a little bit of improvement from the initial presentation. I guess we can debate it either or. Regardless, the owner was slightly happy, content with the procedure so far. Then on February 2022, they sent me this video from home. In this video, we can see that, and we, by the way, we are ignoring for a while the front lameness, okay? That's due to severe pasture and coffee joint arthritis. So we have a significant decrease on the cranial face of the stripe of the left hind. I'm gonna play one more time for the Zoom viewers. In my opinion, this is absolutely the worst I have seen her. This is after she did some rehabilitation here, plus rehabilitation at home. So no question about it that the long-term surgical did not work for this particular horse. We chose this approach because she really did have a classic signs of fibrotic myopathy, and the ultrasound images showed it perfectly. There is no question about it that we have the diagnosis. So how could this happen? Most likely, the epidemiology of this disease is trauma. Some people report that it could be a traumatic incident at work or an injection site, or sometimes they could do a split or a kick, etc. And it's relatively uncommon, only 0.06% in a study that Dr. Peloso did. So there is a theory also that there could be a degenerative procedure going on in those muscles, and we have no idea why it happens. So we call it multifactorial. If it's not traumatic, then it is degenerative multifactorial, and we don't know why it happened so far. The traumatic is pretty self-explanatory. You get the injection, you get the trauma, you get the hemorrhage, you get fibrosis, you get the disease. Treatments. There is a conservative treatment of pretty much doing nothing other than stretching exercises and I learned recently that some people do shockwave, other rehab modalities on the acute stages. Then we have the tenotomy, or we have the myotomy. In our case, the tenotomy, just to make sure we didn't miss anything, we actually had the guy who wrote the paper do it, the latest paper on fibrotic myopathy. He came and do it, Dr. Suarez. We did the tenotomy on that horse. Just a little bit of biomechanics and anatomy. We have two muscles that are commonly involved. Well, there are three muscles could be involved. It could be the sartorius, the semitendinosus, and the semimembranosus. And the semitendinosus comes from the last spinous process of the sacrum, and it gets to the cranial border of the tibia. And it also has an attachment in the calcaneal tendon, which is very sometimes important for this disease. And obviously it extends the hock, it extends the hip, the stifle, and the hock. Then we have the semimembranosus, which could be affected as well, commonly, and it comes from the caudal vertebra of the first caudal vertebra and the broad pelvic ligament, and it goes all the way down to the medial collateral ligament of the stifle, and it extends the hip. An interesting thing about the semimembranosus is that it doesn't do much on the stifle during the swing phase. That's slightly important to understand the pathology of this disease. What we got in the literature, we have several papers. We have the standing myotomy, and then we have the standing tenotomy by Dr. Suarez. And the standing myotomy is used in our clinic a little bit more than the other one, than the tenotomy. The first time we've done the tenotomy is with this particular horse, and that's what we call Dr. Suarez for it. This is a illustration from Dr. Suarez on what the standing tenotomy looks like. And basically, he finds the tendon of the semitendinosus and around the medial stifle, and he transects it. So it's a complete transection of the tendon. And you can see in the surgery that the calcaneal attachment does not get touched in this particular surgery. The calcaneal attachment did not get touched. We'll talk about the paper later, so I'm going to skip through this. I'm going to present you all the case that we did with the myotomy. We cut the muscle, the fiber in the muscle, not the tendon. This is a 5-year-old quarter horse gelding. It's a battle racer, presented in January 2019, and the complaint was poor performance and hind limb gait anomaly. Physical exam was relatively normal, with the exception of a firm left inner thigh, and this is how it was. Video playing okay over there? Awesome. I have no idea what happened. Sorry. Okay, round 2. Good, so we can all see a significant shortening of the left hind with a slap, with a typical slap in the ground. Very typical for fibrotic myopathy. So to summarize, this is a battle racer presented for poor performance. It has short cranial face of the stride and the left hind with a stubby gait and a firm inner thigh. A lot of people come with this disease and they come for quote unquote hook or stifle injections. Then they present like that. That I see that relatively common. That's the complaint they come. This particular horse actually belongs to a vet, so I presented straight for the problem. This is the left hind of French toast. We can see the fibrosis in the center. I apologize for not having arrows here for you. Let's see. Right in the center. Consígueme el pointer. Right here. We can see right here the fibrosis right there. Boom. No way. You see it? Fibrosis right here and right here. So this horse had fibrosis also in the semimembranosus muscle. All right. So basically, this horse, we went to surgery, found that band, and we took that band away. We cut it out just like this. We extended the leg slightly forward, found the band via palpation, and transected. The horse rehab underwater treadmill, and we gave him a fair prognosis for the specific use and definitely a guarded prognosis for recovery to normal gait. This is how he looked after surgery and rehab.
Okay, come back.
I'm gonna play it again.
Okay, come back.
So in this horse, there's no question about it that we saw a significant improve after the surgery. Definitely not 100%, but a significant improve after the surgery.
Okay, come back.
I think we can all agree. Some audience, did we see the video? Yep. All right, good. And this is him walking because it's important to evaluate him at a walk other than the trot. And just to show that
784, Alexis Diaz. Now here to run. Jack's French Frost, Gainesville, Florida. 15, 534 in round number 1, 62nd or 67th. The answer to the question that may be in your mind, had that barrel been leaning like that and stuck like that as they cross the score line, as long as that barrel has not gone down all the way horizontally before they go to the score line, well, that's going to be a qualified time. And that's why we watch it so close. 15's 450 stuck like that as they cross the score line, as long as that barrel has not gone down all the way horizontally before they go to the score line, well, that's going to be a qualified time. And that's why we watch it so close. 15's 451, 15451, draw number 784. That is.
So at French toe, no question about it. That French toe was able to be functional, worked out pretty well for him. The gait still not 100%, but significantly improved. And owner's happy, horse is winning. Obviously went to the World Championship and happy camper. Now let's look at this other case. This case is Madison.
Okay, come back.
She presented
You don't
in
mind
February
coming behind me, please?
2022, and she's a 10-year-old quarter horse man. Let's see if I have a walking video. And unfortunately, I don't have a walking video of her. So I'm
Okay,
gonna
come
have
back.
to of her during the initial presentation. So I'm gonna describe what we see over here for the Zoom audience. Well, actually, I can do like this. Very slow motion. So she have a slight decrease cranial face of the stride of the left hind. And if anybody sees this on the right hind, let me know, because apparently all my cases are on the left hind. So left hind, significant shortening of the cranial face of the stride with the stabby gait. So this sounds very familiar. Now we are expert at this problem. We know exactly what we're going to do.
Okay, come back.
So physical exam findings, she had normal health status. She was much firmer on the left thigh, and she had a short cranial face of the stride on the left hind, more so than the right hind. Now, something very interesting happened on this horse. I want you to look at it. This is a picture of obviously the left thigh and the right one. Left and right. Nothing significant, but if you pay a little bit close attention in person, not in the picture, you might see that the left one is a little slightly smaller, but I'm being picky here, not a big difference. This is a comparison left to right. And this is what the left hind looked like. Obviously, we see fibrosis of the left semitendinosus muscle. Significant fibrosis of the left semitendinosus. Now, in this particular case, I'm trying to tell the owner, hey, I'm going to show you what the normal one looks like. And then I went to the right hind. I said, let me show you what a normal looks like. And here's a picture of the right hind. So I see a significantly unexpected lesion. So this is a very acute or subacute fibrotic myopathy case on the right hind, who I didn't detect on physical exam. And when I went to compare the left hind versus the right hind, we saw that this horse was in the beginning stages of fibrotic myopathy on the right hind as well. I don't see these often. I don't usually catch them that early to be able to see it. So this was a nice scientific treat. So this is the ultrasound images of the left hind versus the right hind. The diagnosis was made. The horse is not too bad. Based on our previous experiences and cases, I told her, let's treat with conservative treatment, do your own rehab, do stretching, and let's keep going. So she sure did that. And this is how she presented yesterday. I wouldn't say she had changed significantly since the initial presentation. I was pretty happy with that. So in this case, now we have to pay attention to the left hind and the right hind as well. I'm gonna play that video again. Not too bad. Not too bad to our opinion. This is her trotting. And this is what it looked like. Now we can see that on the left hind continues to have obviously the fibrotic myopathy that she had before. And on the right hind now is fully consolidated, and we can see the fibrotic band rather than the big hematoma that she was having. Then for fun, we took more pictures, and we noticed that this is the left hind. We can see the fibrotic band. And the right hind, we can start seeing some fibrosis here, as well as on the left, on the semimembranosus muscle as well. I will put arrows here next time. I deeply apologize. I'll put arrows next time. So the semi-membranosus have some fibrotic band as well. And then we just play around, took more pictures. I think this is the right hind with a real nice fibrosis on the semi-membranosus. It looks better here than it looked yesterday. With a nice semi-membranosus fibrous band right here. Good. So let's talk very quickly about the paper, and then we'll open for discussion. I analyzed the paper of the standing myotomy because obviously out of all we did all three cases. I presented the three cases, right? One with the tenotomy of the semi-tendinosus muscle. I present you a case of the myotomy, and then I present you a case with no surgery. So analyze the paper for the standing myotomy. I believe this paper came from UC Davis, actually. It was a retrospective study of 22 cases, and they put all horses just like ours, just like these cases, that presented for fibrotic myopathy. Pathognomic signs, shortening cranial face of the stride with a rapid caudal movement and inducing the slab, all right? The follow-up was obtained from owners. Pay close attention because the follow-up was obtained from owners and included client satisfaction and return to performance. Average age, just like very similar to ours, from 4 to 25 years old. Most of them were quarter horses, significantly overrepresented, but it did happen in thoroughbreds, Arabians, Andalusians, saddlebreds, etc. Most of the cases were due to documented traumatic case, whether it was a kick, a jump over the fence, or something traumatic, or a vaccine abscess, and then other cases, they had no idea why it happened. The results were like following. Some horses, the horses got surgery, and they went just like we did with French toast. They transected the fibrotic band, and then they walk the horse out from the stocks, just like we did with French toast and the first case. If it didn't respond right away, they cut it again, which is different than what we did with our first case. It didn't respond again, and Dr. Suarez decided, no, let's rehab it, and some of them actually get better after the rehab. Sure enough, she got better, but then she came back. So in this particular case, some of them got surgery twice, right away. Post-op complication was not many other than a transient fever and some wounds opened up the surgical site. Then they went home on stall rest, then 5-minute trotting, and it increased in 5 minutes per week. They tried to give heel work, but apparently in California around Davis, there's not a lot of heels, so not all of them got their heels. And then they were able to canter after 4 weeks. 16 horses were available for follow-up, and 13 horses were satisfied. 8 had a recurrence. Now, interesting how this gets evaluated, because in our case, depending on the time that you ask, all horses were satisfied, but none of them actually was completely fixed. 12 horses were intended to go to athletic use, and 8 returned to athletic use. 4 were retired to paddock later on. So not too bad, they got about 50%. In conclusion, this paper presented horses with fibrotic myopathy that they operated standing with a fair prognosis to return to athletic performance. But like I say, careful interpretation when we read these papers, because the owner satisfaction is not going to always necessarily match the true result of the procedure. Does that make sense? And doing retrospective studies is a nightmare. Obviously, we have probably all done it, because you have very little control of what happened in the past, and you have to analyze so many variables. So it's going to be very it's going to be very difficult to get a lot of data on what is best or not. So my personal opinion at this moment, I do a lot of these horses conservative. We do not do surgery in a lot of these horses, like the last horse that I presented. If it's super bad, like French toast and a young horse, then we go ahead and do the surgery. All rehabilitation is in this paper was sent to the owner. There's no standardization for rehabilitation, so we really need to figure out how we can do a standard rehabilitation technique. A lot of these owners say, yeah, the horse did great while he was rehabilitating, and then as soon as we stop the rehab and the stretching and the work with the horse recurred and got worse again. Another thing that the paper could have improved is that it doesn't quantify the degree of improvement. I think that it would be a very good idea to be able to measure, and there's significant softwares now that could actually measure the degree of improvements of this horse and measure if we actually have, what kind of resolution do we have. So in summary, it's a retrospective study, is a difficult study to do, no question about it. And for sure, we need to come up with better ways to improve the follow-up and the rehabilitation of these horses. I'm not gonna bore you a lot more with it because we're running out of time. So open up for question, discussion, and if you want to see any of the videos again, or if you want to share cases, let's do it.
Would you have preferred to do the myotomy to the first case instead of the tenotomy? Do you think that would have had a better success or not?
I really wonder, what if we would have done both? It's a 25-year-old horse. Now, this is one of those cases that I bring the expert on the topic, so I don't really, I don't put a lot of input when we do that, because it would be a lot of speculation. You can just wonder, you know. But I would wonder if we do both and we start cutting, we cut the tendon, and if we also cut more fibrotic bands, maybe she will get better. Now, things to consider on this horse, she's 25. You saw that she looked cushionic. She had severe arthritis all the way from neck to tail. So on that particular horse, it was an interesting decision-making process, and we went with the least traumatic. With no results, obviously, so anything can be argued. But maybe we should have done both maybe we should have cut both on that horse. Now she's 27. Maybe I don't know if I would be brave enough to try to cut it. No questions? Comments? Oh, Dr. Colton told me that in this practice they do a lot of shockwave with this, right?
Shockwave typically is a kind of follow-up and adjunctive treatment of rehab after we treat PRP. We had a lot of success in treating these acute kind of subacute cases with PRP and then really aggressive rehab. And the client asks, when can we stop stretching? When can we stop doing all this rehab? And there's pretty much never. You're doing this as long as you have this horse.
Rehab for life. Now, that the PRP, you would do it when you saw Madeline, for example, on the right side.
So yeah, for Natty, yeah, when you have that kind of active hematoma, that active muscle tear, if the client can come back in, a couple of weeks, once that starts to kind of consolidate, suck up a little bit, that I think that would be better, just because you're diluting the PRP with a lot of that blood that's in there. But probably 8 out of 10 cases, the client can't come back, they're hours away, so you just plug on that day.
And Dr. Colton used to practice on a busy sports medicine practice in California, so you probably saw a lot of fibrotic myopathy, you know.
Probably seen 20 in the last 2 years.
Yeah. Dr. De Angel, I have never seen it in a Paso Fino. Have you? You do a lot of Paso Finos over there.
No, I don't recall doing one. I wonder for surgery, would it be different to incise the muscle versus debride it, or you know, yeah, debride it as a undermine it, I should say, like undermine it. You know what I'm saying?
No.
As a surgical technique versus incise it with a blade versus doing an undermining of the tissue.
And do what with a fibrotic band?
You know, break it up, like you know, like opening your scissors versus incise it. You know what I'm saying? If you can break it up.
When you do the surgery, that fibrotic band, when you're in there, so you go in and you start opening up with the mayo, right? Until you find the band. And when you find the band, that sucker is hard. It feels like a rock sometimes. And you even try to cut it with the mayo, and sometimes the mayo doesn't even do it. So I wonder how easy would that be. I'm not 100% sure. And remember, and then when they reoccur, what happens is what you cut and all the muscle that you cut, the band doesn't necessarily come together, but the muscle around it then continues to fibrose, and that's other muscle fibers then recreate that injury. But I personally don't know how easy it would be to open up like you're saying. I guess the rest of the muscle, yes, for sure you can transect all that muscle. We could try it. We could try for sure and see what we get. But I know for sure I cannot personally cut that band on some of these cases with the mayo. To what?
You get an open up the count, like an open surgery.
It's extensive. It is extensive. Yes, usually it's extensive. And then in addition to that, there's some really interesting blood vessels around that you want to stay away from. Good. Has anybody injected steroids directly in it?
Yeah.
Success?
Not really. No, and I've also seen one case that was really severe, an older mare, mid-20s. Did not present for this, but she had really significant mineralization all the way down both semitendinosus. I mean, there were big rocks in there basically. History was unknown, so I'm not sure if there was some treatment with steroids in that at some point.
So there's a thought that steroids could mineralize even more.
Yeah, so after I saw that, I kind of stayed away from that approach.
Wow.
She was severely affected.
Good. So if you guys didn't hear it online, it's a case in California that they suspected it got injected with steroids, and then it got actually a lot worse, rock hard, severe fibrosis. All right, guys, it's been real great pleasure. Thank you very much for joining us.
Thank you.
Thanks, Doc.
Have a great day.
Thank you.
Good day.